Welcome to the Practicing Clinicians Exchange podcast series, Individualizing Management of Uncontrolled Asthma, New Strategies. This is the first of two podcasts developed from a live recording during the PCE Symposia series in June 2021. Each episode is eligible for CE/CME credit. To receive your credit at the conclusion of the podcast, please go to pce.is/UA. This episode is certified for 0.50 ANCC contact hours and 0.50 AAPA credits.
I am very pleased to introduce Dr. Samuel Louie, Professor Emeritus in the Division of Pulmonary and Critical Care Medicine at the University of California, Davis, in Davis, California. He's going to be presenting on individualizing management of uncontrolled asthma, new strategies. Before I move into the first slide beyond this one, I want to tell you that Dr. Louie, who goes by Sam, has won the Outstanding Clinician Award by the American Thoracic Society. He didn't know I was going to say that. So that's why he's shaking his head. That is quite an honor, my friend. And I used to use the term well-deserved, and my wife said, no, that's earned. That's well earned. So congratulations on that, Sam. Our learning objectives for today are to apply current methods to recognize the features of uncontrolled asthma and asthma phenotypes, particularly severe asthma, to individualize treatment with add-on biologic therapy based on patient and disease-specific factors, and finally, to utilize strategies to enhance adherence to therapy and improve clinical outcomes. Okay, and with that, I'm going to turn things over to you, Sam. Thank you for joining us.
Well, thank you, Larry, Professor Herman, Dr. Herman. I'm really delighted to join you, Larry, in this educational program. Moreover, I want to wish and declare my respect and admiration to all nurse practitioners and physician associates for their dedication and critical role in the practice of medicine. A lot of times what we have to do is let go of the past to learn again. And what we have on this slide is a statement that asthma is highly heterogeneous. In other words, it's very diverse. I think this is an appropriate place, Larry, to share with our audience, our colleagues, a quote from Eleanor Roosevelt. She said, "Learn from the mistakes of others. You can't live long enough to make them all yourself." I think it's a mistake to think asthma is a single disease. Asthma is not a single disease. Asthma is a syndrome. It's driven by inflammation. And you and I, after years, if not decades of practice, recognize that patients wheeze, they cough, and that's due to airway hyperresponsiveness. And they can, if you test them with spirometry, you can document the fact that airflow limitation exists. But what we did not know until very recently is that we can clinically recognize certain types of asthma that may be responsible for the uncontrolled symptoms and their frequent exacerbations. And just like type 1 and type 2 diabetes, we're being asked to accept a certain point of view. There is type 2 inflammation, which is adaptive immunity. This is the allergic inflammation, and it is characterized by the presence of a certain cytokine mixture. In this case, IL-4, IL-5, IL-13, which in the end may recruit eosinophils into the airway. On the other hand, there is non-type 2 inflammation, probably involving type 1 and type 3, but to put it under one umbrella, it's basically type 2 inflammation, which is really a part of the innate immune system. And if you look at the figure on the right, you'll see the dermatology of asthma. Then in the center, you see the immunology, and the very bottom where you see the bronchial smooth muscle cells, that's the neurology of asthma. We can now target type 2 inflammation or the adaptive immune system that gives rise to allergic inflammation with biologics to modulate the cytokine pathway involving IL-4, IL-5, and IL-13. What we know from science, and these are the key points to take home, is that IL-4 and IL-13 drive IgE production and eosinophilic infiltration. IL-4 and IL-13 drive smooth airway muscle hyperresponsiveness, airway remodeling, and mucus overproduction, whereas IL-5 drives eosinophil differentiation and survival. How does this apply to the patient? Well, we're going to basically explore that together when we work on a case study. The patient's name is Grace, and we'll see her momentarily. But to help us in the task of trying to manage and treat patients with asthma, we have guidelines that have been updated. In fact, 2 sets updated very recently. The Global Initiative for Asthma is updated every year. There is a pocket guide available that you can download. The NIH very recently updated their guidelines after 13 years, but they, in my opinion, failed to address the role of biologics. They omitted studies that looked at the efficacy and safety. Furthermore, they added an additional step. There are 6 steps to the NIH guidelines, whereas there's only 5 steps to the updated 2021. And we're going to basically use the GINA guidelines as the foundation for our discussion. But we can't really talk about asthma without basically mentioning the dangers from COVID. What we have learned is that patients who are well controlled, and it really doesn't matter if they have mild, moderate, or severe asthma, but when they're well controlled, there's no evidence of increased risk of severe COVID-19 and death. On the other hand, if asthma is uncontrolled, if asthma is so difficult to control that you and I have to prescribe oral corticosteroids, or if the patient's been hospitalized, they're definitely at risk for COVID-19, infection, and death. I think it's very important to remember that asthma control is really what we want to help patients achieve. And we do so by reducing impairment from asthma and reducing the risk not only of exacerbations, but adverse drug side effects, such as those that can come from oral corticosteroids. So the GINA guidelines have provided, again, a caution to all of us to use strict infection control measures, to avoid doing spirometry if we can, and to avoid the use of nebulizers. But really, again, to get to learning about this case in a way that will endure as we go back to work this coming week, let's talk about Ruth. This is our hypothetical patient. She's a new patient because her healthcare coverage has changed, and she is now our patient. She's a nurse practitioner. Based on her photograph, it looks like she's very discerning. I think she's kind of skeptical about what we're going to do for her. But her chief complaint is that she's wheezing and she's short of breath after experiencing a recent exacerbation that required her to go to the emergency room. And that basically is a serious exacerbation that requires urgent services. She's a non-smoker. She quit 30 years ago. And we discovered through the history that she was just very recently diagnosed with asthma by her previous provider. No spirometry was ever done, and a review of her comorbidities revealed that she has chronic rhinosinusitis, and you look up her nose, she's got nasal polyps, and they seem to be well controlled with the use of intranasal steroids.
She initially presented 1 year ago with wheezing and shortness of breath, and that occurred after exercising. And it also happens when she's exposed to cigarette smoke or strong perfume. She is sometimes awakened at night with wheezing. She complained of chest tightness that worsened when walking the dog. And based on clinical and new spirometry findings, Grace was confirmed to have asthma, not COPD. On physical exam, her lungs are clear to auscultation with a moderate wheeze on forced expiration. ENT, I thought we said that we saw a nasal polyp, but here it says no nasal polyp visible. FEV1 over FVC ratio is 69%. FEV1 is 59% of predicted, and her bronchodilator response increased FEV1 by 15% and 300 mLs, and an increase of FEV1 by greater than 200 mLs and greater than or equal to 12% after using albuterol confirms a diagnosis of asthma. So with that as our setup for Grace, I'm going to flip it back to you, Sam.
Well, when you have a case like this, Larry, it's very important to confirm the diagnosis of asthma. Easily 30% of people with asthma actually do not have asthma. So this is the checklist that we need to have in mind. It goes from bronchiectasis all the way down to vocal cord dysfunction. So as clinicians, we have to be concerned about the possibility of cardiac asthma or congestive heart failure, COPD, which can overlap. We have to be worried about drug side effects. Again, ACE inhibitors, beta blockers, aspirin, even NSAIDs, which are used so often, can in fact cause people to cough and wheeze and interfere with their quality of life. But again, chronic pulmonary embolism can also do this. And all of these may also be found together with asthma, which is why pulmonary function tests, particularly spirometry, is important, because you want to make certain that it is consistent with asthma. In fact, what we have on this slide is what is a normal flow volume loop. And notice the bottom of the flow volume loop. It looks like the bottom of a chicken egg. Well, again, when you have asthma or COPD, you begin to trap air. The x-axis refers to your vital capacity. This patient normal basically has about 5 liters. But when you basically have asthma or COPD, you begin to trap air in your lungs. And the ability to basically move air in and out of your lungs is compromised. And so you get much less. And notice that border, the straight border, the angled border, looks like it's been scooped out, basically with an ice cream scoop. And this is very typical of somebody who has had advanced asthma, because most people that you'll find in your clinical practice will in fact have normal pulmonary function tests, which may basically allow you to talk about the possibility of doing a methylcholine challenge test. Because Grace basically showed a bronchodilator response, please keep in mind that the American Thoracic Society has asked us to accept their consensus criteria. If somebody improves by 12% in addition to a 200 ml improvement in their FEV1, FEC, then that's a bronchodilator response to 4 puffs of albuterol. The other thing to take home is that vocal cord dysfunction takes a pair of scissors and cuts off the bottom of that flow volume, which represents the inspiratory flow, whereas the top represents the expiratory flow. And if the flow volume looks like it's been squeezed in, like everybody tight inside of an elevator full of people, that's restrictive lung disease. So that's one of the key take-home messages. Use spirometry to confirm the presence of expiratory flow limitation. With that, again, using the guidelines not as a mandate, but as a tool to help us individualize therapy, we can begin to outline short-term and long-term goals for the patient. And again, it's very important to look at the treatable traits of asthma, symptoms and exacerbation, and again, the risk of adverse drug side effects. And so to help us, what the GINA guidelines, again, based at the World Health Organization, has asked us to use asthma control-based management. In other words, at every visit, assess the patient's progress with a tool such as the asthma control test, adjust their therapy if needed, and then have them come back to see you in 2 to 6 weeks to review the response. And this is done at every visit. In fact, what I tell my patients very often is that I'm no more than an asthma shoe salesman. I have to find the medicine, and the treatment plan that will help the patient achieve the goals. The next slide shows you the new wrinkle in the GINA guidelines. Again, this is based on the evidence from the published literature showing better outcomes and really better patient safety if patients basically are introduced to this road or this pathway for achieving asthma control. If you look at this slide, again, you see in the top left-hand corner the cycle of management: assess, adjust, and review. What you see below that are 2 arrows going from your left to your right. You see above the dotted red line the current recommended and preferred control regimen. This is very different than what we've been doing in the United States. The GINA guidelines are actually recommending that we introduce patients who need to control their asthma an inhaled corticosteroid and a fixed dose combination with formoterol, and to have patients use this and to adjust their use of the ICS formoterol with increasing dosages if necessary, up to 8 to 12 puffs a day. And again, to assess their asthma control and to make sure that they're actually able to avoid all the symptoms, not have exacerbations, and to enjoy life at home and life at work. Their option is what we've been doing for many years, and that is to use inhaled corticosteroids to add a LABA over time and to increase the dose as needed, even if necessary, to increase the dose of the inhaled corticosteroid from low to medium to high dose. But if patients remain uncontrolled, then we all end up at the far right, where we will consider adding on a LAMA, a long-acting muscarinic antagonist, or even go to a high-dose inhaled corticosteroid fixed dose combination with formoterol. And this is where we can begin to really ask ourselves, do we really have asthma? Is there a comorbidity that's interfering with asthma control? Do we need biologics? The actual guidelines from the GINA document updated this year looks like this. Again, you see the dotted red line separating the preferred controller pathway or road versus the optional, basically the option that's available to you. But notice an additional change, and this is, again, not approved by the FDA, the way we're basically asked to use inhaled corticosteroids in a fixed dose combination of formoterol. We're also asked, basically, when patients in the option pathway, to use inhaled corticosteroids whenever albuterol is taken. In fact, the GINA guidelines, as well as the NIH guidelines, have begun to recommend as needed low-dose inhaled corticosteroid formoterol as the preferred rescue agent. But that is not FDA approved currently. Only albuterol or levoalbuterol is FDA approved for rescue. As a consequence, it's very important to have a discussion with your colleagues, but I think in the end, we need to adhere to an evidence-based stepwise approach such as GINA and help guide our patients to finally controlling their symptoms and to minimize the risk for exacerbation. You and I want to eliminate the situation where the asthma is controlling the patient. You want the patient to control their asthma. And to do that, we need medications in addition to avoiding triggers. And you're all basically of experience and you have expertise. Inhaled corticosteroids are first line. And then you can add on inhaled corticosteroids, a LABA, a leukotriene modifier, even theophylline if necessary. But again, ICS, a LABA, and a LAMA at step 5 in the GINA guidelines is what is currently recommended. Returning to Grace.
So 1 year ago, she was a GINA step 2, previous PCP started therapy, daily low ICS maintenance therapy, albuterol inhaler for rescue, friends at work, refills her albuterol, no asthma action plan. 6 months ago, she was GINA step 4, poor control of her asthma symptoms. PCP stepped up her therapy. She was on fluticasone, salmeterol, DPI-1 inhalation of 250/50 twice daily, which is a medium ICS dosage, and an albuterol rescue inhaler. Last week, she had an exacerbation on a cold, dry evening with fireplace use, chest tightening, wheezing, trouble breathing. Albuterol didn't help, went to the ED, received nebulized bronchodilators and prednisone burst, tried to follow up with you as a new patient. So with that being said, uncontrolled asthma can be recognized by choose all that apply. Is it the asthma control test, an ACT score of less than 20, exacerbations requiring an ED visit or hospitalization in the past? 3 is frequent severe exacerbations requiring oral corticosteroids for rescue. 4 is an FEV1 of less than 60% predicted, or you are uncertain as to how you can recognize uncontrolled asthma. So actually all 4, number 1 through 4, are all examples of a patient who might have uncontrolled asthma. So for the next one slide, Sam, I'm going to flip it back to you and then I'll take it back.
Thank you, Larry. According to GINA, the level of asthma control is assessed retrospectively. It is the extent to which the symptoms, the manifestation of asthma can be observed in the patient or have been reduced or removed by treatment. And this is something that needs to be done rather frequently. And again, it's important to have patients come back and to evaluate them in a 2 to 6 week period, and if not, in very months. Larry, back to you. We have another question.
Thank you. So Grace takes the ACT and scores a 9. What does that indicate about her asthma? Is it 1, it's well controlled, 2, it's not well controlled, 3, it's very poorly controlled, 4, very little, the ACT has not been validated to assess asthma control in clinical practice, or 5, you are uncertain? We will chat about this. Okay, and 37% of you said it is very poorly controlled, and that is absolutely correct. And let's go through this very quickly. As in assessing it, this can be self-administered. You could put it on a tablet. You can automatically download it to your EHR. It could be a piece of paper and scanned in. If the total score is equal to or less than 19, asthma is not well controlled. And as we look at this, going from the first, second, third, fourth, and fifth question, we see that she scored a 3, a 2, a 1, a 2, and a 1. So if I add that up correctly, her score is so low, she is very poorly controlled. And I'm not going to go through this entire thing because you have this in your slides, but her asthma action plan, this is a strategy to address short-term changes. You prescribe a peak flow meter as part of her action plan, and you show her how to use it and instruct her on how to interpret the results based on her personal best result of 440 liters per minute. And you show her what is the green zone and what should she do? What is the yellow zone when she starts to, and this will predict even before she starts to wheeze, the peak flow will be a better indicator. And when she gets into the red zone, what she needs to do, including rescue medication, prednisone that she can have at home, and to call her asthma care provider. So I'm going to flip it back to you now, Sam.
Thank you, Larry. The asthma action plan really helps patients recognize when they are a danger to themselves. Again, it's so important to make time to educate patients. They need to know when, how, and how long to use or increase their treatments at home, and when to basically seek emergency services. And this is really part of the effort to individualize the patient's management care plan so that they can actually manage their asthma well. Because even patients with mild asthma are at risk for mortality from status asthmaticus. So help your patients write an asthma action plan that is tailored to their individual needs. Again, in addition to that, recognize and manage comorbidities. And this is where you may, in fact, have to involve a specialist. You may have to refer the patient. But the things that you see on this slide are very, very commonly encountered. Risk factors that increase the likelihood of exacerbations, I cannot state more emphatically than Larry has. It's really important to assess asthma control with the asthma control test. If it's 19 or less, you have an opportunity, you have a mission to try and help the patient achieve a greater score between 20 and 25. A single inhaler of albuterol should last the patient a whole year if they have well-controlled asthma. So anytime a patient requires an albuterol inhaler, they're increasing the risk of death. Look for smoking. Look for anxiety, depression. Again, really look for a history of severe exacerbations requiring ER visits the previous 12 months or a need for corticosteroids. These basically will help you identify patients who need extra special attention. So before considering any step-up in therapy, this is a very important checklist to me, Larry. I think our audience needs to really remember inhaler technique is very poor in patients. The majority of patients fail when it comes to using the inhaler correctly. Many patients, as a consequence, not feeling better, they stop taking medications. So adherence is always an enemy when it comes to helping patients achieve control. Be aware that patients may not tell you the whole truth. They may be allergic to their pets. They may smoke tobacco. They may basically continue, or you may or may not be aware that they're taking other medications that may interfere with the actions of their prescribed medications to improve their airflow limitation. And again, it's just so important to keep in mind that I could have the wrong diagnosis. So before considering any supplement therapy, make certain that the patient has had a good 2 to 3 months of control of therapy. Correct common problems for you step up treatment, and do not be shy in asking for a consultation.
Thank you so much for listening today. To hear more about Grace and how her uncontrolled asthma was managed, tune in to the second episode of this series. You can access that as well as claim your credit for this episode by visiting pce.is/UA.